So again, today we are here with another exciting and very interesting lecture regarding the abdominal hernias. So I have already discussed what we're going to discuss in today's lecture regarding the hernia and the formation of the hernia, the pathophysiology, and obviously the different kind of the surgical options, like maybe it's the open repair or maybe the mesh repair. So today we will be talking about this. So let's start. First of all, we will talk about a little bit of the anatomy of the abdominal wall. So first of all, obviously we have the superficial fascia. First of all, we have the skin, then we have the superficial fascia, subcutaneous tissue, and just beneath the subcutaneous tissue, we have a layer of the muscle, which is called as a rectus abdominis muscle. And let me tell you that these are on the both sides. This is rectus abdominis on the right side, and this is rectus abdominis on the left side. And in the midline, basically they're joined together, and in the midline there is a linea alba, and rectus abdominis muscle is enclosed in a sheath, which is the anterior rectus sheath and the posterior rectus sheath. So if we go deep down after the rectus abdominis muscle, there's another muscle which is called as external oblique, and here you can see the aponeurosis of the external oblique muscles. So this is basically the aponeurosis. This is the muscle, and it is just underlying beneath the rectus abdominis muscle. Then we have the internal. Here we go. This is the internal oblique muscle, and then we have deep down we have the transversus abdominis muscle. Then we have the transversalis fascia, and then going deep down we have the peritoneum and different kinds of the viscera. The intraperitoneal organs or the intraperitoneal structures we will find out there, right? Then we also have the latissimus dorsi, which is basically posteriorly located. We have this extraperitoneal fascia as well. We have the fascia transversalis, we have already told you, because just beneath the layer of the internal oblique, we have the transversalis fascia, and this is the parietal peritoneum. We have to open the parietal peritoneum, then we go we enter the peritoneal cavity, and we have the visceral peritoneum as well, because the visceral peritoneum is actually adherent to the different viscera which are located in the peritoneal cavity. So there's another muscle which is the psoas muscle major. It is also located basically retroperitoneal. It's a retroperitoneal muscle in the posterior aspect of the abdominal wall. We have the rectus spinae muscle, which are basically the muscles of the back. You can appreciate here these are the vertebra, and if we are going away from the body cavity, so actually it's enclosing the posterior aspect. We have the rectus spinae muscles, and here you can also appreciate the abdominal aorta, and just close to the abdominal aorta, this is the inferior vena cava, and we have also the other muscles of the back, which are the quadratus lumborum. So starting from the anterior to posterior, anteriorly we have the skin, we have the superficial fascia, and then when we open the superficial fascia, we go deep into the abdominal cavity as well, and we approach the rectus abdominis muscle, which is enclosed into a rectus sheath, which is basically the anterior rectus sheath and the posterior rectus sheath. Just beneath the rectus abdominis muscle, we have the external oblique, then we have the internal oblique, then we have the transversus abdominis muscle, then we have the transversalis fascia, and then obviously we reach the peritoneum. We open the peritoneum, which is basically the parietal peritoneum, and then we enter the peritoneum, and then we are into the peritoneal cavity. So these structures, which are basically the latissimus dorsi, quadratus lumborum, rectus spinae, and psoas, these are the muscles of the posterior abdominal wall. We can say that these are the muscles of the back, especially the erector spinae muscle. This is basically the erector spinae. These are the muscle of the back, which are enclosing or which are just surrounding the vertebral column. So this was about the anatomy of the abdominal wall. You can see here basically this is the anterior aspect of the abdominal wall, but Why is this thing important to know about the anatomy of the anterior abdominal wall? If you go back into the previous slide, I told you that this is the linea alba, and the linea alba is basically in the midline. Coming here, we can say that into the next slide, this basically, if we open and we go deep down into the abdominal cavity, the linea alba is the midline raphe. Basically, because on the right we have the rectus muscle, on the left we have the rectus muscle, which is basically enclosed into the anterior and the posterior rectus sheath, and there in the midline the sheath is deficient, and there is a linea alba, which is basically the midline raphe. Now the thing is, why is it so important to know about this linea alba? Because this is the point of the potential weakness. This is the area of the weakness, and most of the abdominal hernias are basically developing from this defect, the defect in the linea alba. So first of all, you need to know what is a hernia. Hernia is basically the protrusion of the body, or protrusion of the contents, maybe through the anterior abdominal, maybe the anterior abdominal wall. Particularly if we talk about the abdomen, so we know that the hernia is a protrusion of the contents from the abdominal wall, and through a potential weakness or through a potential defect. Right, so I told you that linea alba, this is basically a midline raphe, and it's an area of the potential weakness. So that's why this midline raphe and surgical anatomy of the body is really, really important, because through that defect, the peritoneum can come. It can be a fat, it can be omentum, or it can be, because if the defect is in the linea alba, right? So it's a midline raphe. So what happens? There can be herniation of the fat, there can be herniation of the omentum, or there can be a herniation of the gut, maybe a small bowel or maybe the large bowel. So this is important to know that what is the hernia. You can say that it is the protrusion of the organs, or the protrusion of the contents from the abdominal cavity through the abdominal wall, through that potential defect or the potential weakness, right? Now the question arises, what are the sites? So basically, there are multiple sites through which a hernia can be protruded, right? So there can be anterior aspect of the wall, or they can come from the posterior aspect of the wall as well. You can see that the hernia is basically protruding from the back. That means basically this is the back of the abdominal wall, and I'll tell you in detail like what kind of the hernia are basically coming from the back. And also this was basically the anterior abdominal wall. I told you that this is a midline, so the midline is basically the point from which a hernia can protrude. Coming back to this slide, you can see these are multiple sites, but they're basically involving the back, and there are multiple sides in the anterior abdominal wall basically, and the hernia can protrude from here. You can see in the midline, this is basically the epigastric region. So whenever the hernia is coming from the epigastrium is a point starting from the xiphoid process above, going below to the symphysis pubis. So whatever the hernia, if basically the hernia is coming from that, this is called as epigastric hernia. So these are the sites of the epigastric hernia as well. Some of the hernias are either coming from the umbilicus, because what happens is some are called as umbilical hernia and some are called as a paraumbilical hernia. Most commonly, the hernias which are in the children, they are the umbilical hernia. Why? Because that's the site for the umbilical cord, right? So whatever there is always a potential weakness left in that umbilical part. So, but what happens that whenever there is a process of the development or during the adulthood life, the defect is closed. but sometimes actually in the later life that the defect is again because due to the increased abdominal pressure or cuffing or straining, there is another defect which is produced out there. So in adults it is para-umbilical hernia, and in children it is umbilical hernia. So these are the sites of the, particularly these are the sites of the epigastric hernia, and these are the site, basically this is the umbilicus, and either is it coming from the umbilicus, this is called as a umbilical hernia, and if it's coming from the region around the umbilicus, that's called as the para-umbilical hernia. So this is basically the spigelian hernia, which is coming from the lateral border of the rectus sheath. So you can see that this basically here is the rectus muscle, here is the rectus muscle, and basically this is the spigelian hernia. You can also see here this is the epigastric hernia, and this is already told you the side of the umbilical hernia. Already told you the side of the para-umbilical hernia, and we have the spigelian hernia. So the spigelian hernia is a hernia which is coming from the lateral border of the rectus sheath or the lateral border of the muscle as well. This is the inguinal hernia, which is basically lying above the inguinal ligament. This is the inguinal hernia. Below the inguinal ligament is a femoral hernia, and this is the obturator hernia, just which is close to the femoral hernia. So these are about the hernias of the anterior abdominal wall. The epigastric hernia, the para-umbilical hernia, umbilical hernia is here, the spigelian hernia, which is coming from the lateral border of the rectus. This is the inguinal hernia above the inguinal ligament in the inguinal canal, the femoral hernia below the inguinal ligament in the femoral triangle, and the obturator hernia as well. So if we talk about the posterior abdominal wall, you can see this is the superior lumbar hernia, this is the inferior lumbar hernia, and these are basically the hernias which are coming from the lumbar triangle, which is located at the back. So one coming superiorly is a superior lumbar hernia, and the one coming inferiorly, that call it inferior lumbar hernia, but they are located in the lumbar triangle, right? And we have the gluteal hernia and with the sciatic hernia as well. But let me tell you, these lumbar, gluteal, and sciatic hernias, these are not very common, but commonly we encounter the epigastric, para-umbilical, umbilical, spigelian, inguinal, femoral, and obturator is, that's not very common as well. But most commonly with the umbilical or para-umbilical hernia. In children, it's umbilical, and in adults, it's para-umbilical hernia. We have the epigastric hernia as well, and sometimes we have the patient may come to you with an incisional hernia as well. So incisional hernia can be at the site of the potential weakness because whenever a surgery is performed, whenever the wall is cut, although there is fibrosis, but the strength of the wall is left 70%. Like that means the wound is healed, there's fibrosis, there's tension, but still the wound strength becomes 70%. It reduces down to 70% instead of 100%. So at that 30% deficit, or that 30% defect, actually that basically stimulates the formation of the hernia. So this was about the sites. We're going to talk about the anatomical causes as well. But let me tell you, we'll talk about weakness, developmental failures as well, but there are hernias as well, because sometimes there's a weakness, right? Weakness in the abdominal wall. This weakness can be genetic, or this weakness can be inherited, right? Inherited, genetic, or acquired, right? In case of collagen diseases, obviously our skin, there's elasticity because of the collagen. The tensile strength is because of the collagen, and it's mostly type 4 collagen. But in conditions like the Marfan syndrome or Alagille syndrome, in which there is the collagen deficiency, actually there's a problem and there's a weakness in the wall. Because of that weakness, what happens is there's always a potential weakness, there's always a potential for the contents or the organ or the viscera or to herniate from that particular site or that particular defect. So one cause is the weakness. The weakness can be genetic includes the collagen vascular diseases, or can be acquired because of the surgery, because I already told told you that sometimes whenever we cut the abdomen, we go deep inside and we cut the muscles, or we cut the rectus sheath, we cut the linea alba. Actually, there's basically the tensile strength is decreased, because whenever there will be contraction of the wound, there will be fibrosis. 70% of the tensile strength would be recovered. Like there is a 30% deficiency. So what happens is the weakness is developed. So the weakness can be genetic, or the weakness can be acquired. The other is a developmental failure, right? What do you mean by the developmental failure? Sometimes, like if you talk about the diaphragmatic hernias or hiatal hernias, these are basically the hernias which are, there's a defect in the diaphragm, and the contents herniate from the diaphragm, like in case of the diaphragmatic hernia. So there's a developmental failure. We are not going to talk about the diaphragmatic hernias or the hiatal hernias today. Maybe in other lecture we're going to cover that, but actually you should just remember that there can be the developmental failures, and because of that developmental failures later on in life, combining with the environmental factors and your lifestyle, like smoking or physical exercises, training, that developmental failure can manifest itself, and there can be either they manifest in the early ages or they manifest later in the ages, but there is a manifestation due to the development of failures. There can be genetic weakness of collagen, already told you, because this genetic weakness of collagen will lead to the potential weakness, and whenever there's a potential weakness, there is a chance of herniation. Sharp and blunt trauma. There can be abdominal injury, there can be a gunshot injury, or there can be a sharp and the blunt trauma. So that's why whenever there is a trauma, there's a rupture of the protective barrier, and obviously because of that particular site, the trauma site, there can be the herniation. Weakness due to aging in pregnancy. Why aging and why pregnancy? Because in aging, when you are in the process of aging, there's a loss of elasticity of the skin. There's no regeneration. The process of the regeneration is very slow, and there's no much of the collagen deposition, and the elasticity of the skin is also lost. So because of that, aging leads to the weakness. Particularly if we talk about the inguinal hernias, they're very, very common in the old age male people because of the potential weakness which is developed in them due to the process of the aging. The other thing is the pregnancy, because what happens at pregnancy increases the intra-abdominal pressure. Whenever there's increase in the intra-abdominal pressure, there will be more of the stress on the protective wall, and there will be a defect, and there will be herniation. So this was all about the anatomical causes. We talk about weakness, we talk about the developmental failures, we talk about the genetic weakness of the collagen. There can be sharp and the blunt trauma, there can be weakness due to aging and pregnancy. All those conditions which are basically increasing the intra-abdominal pressure, like coughing, straining, heavy exercises, weightlifting, being involved in athletics, because there's a lot of excessive physical activity. So these are all the conditions which basically precipitate, and there's a weak point, and the contents herniate through that particular weakness. There can be primary neurological and muscle diseases as well. So these were the anatomical causes, and excessive intra-abdominal pressure already told you, right? So we talk about the pathophysiology, how basically this is developed. Number one is a constipation, two is excessive coughing, obesity. All these things, they actually increases the intra-abdominal pressure, right? We have a negative intrathoracic pressure and we have a positive intra-abdominal pressure, right? But whenever there will be more, because a body can actually tolerate the pressure, there are some pressure restraints. A body can tolerate up to a limit, but whenever the limit is increased and there's more of this straining onto the body, the wall is a weak point, especially the midline raphe, the linea alba. That's a potential weak area, and whenever you put more pressure on it, there will be a defect, and there will be herniation of that particular contents through the abdominal wall. Constipation, it increases the intra-abdominal pressure. Excessive coughing increases the intra-abdominal pressure. Obesity increases the intra-abdominal pressure, right? So there can be prostatic symptoms as well. Why these prostatic symptoms are related to the formation of the hernia? Because whenever there are prostatic symptoms, you know that actually the urethra is passing from that. The prostatic urethra is actually surrounded by the prostate. So whenever in the process of aging, there's a benign prostatic hyperplasia, or the enlarged prostate can be because of the carcinoma. See a prostate. So these symptoms, actually what happens, that this is the prostate, this is the bladder, this is the urethra, which is coming down from the bladder into the prostate. This is the prostatic urethra. Whenever the lobes of the prostate are increased, they are increased in size, there's benign prostatic hyperplasia, they actually compress this urethra. So whenever this urethra is compressed, there's a back pressure of the urine into the bladder, and this dilated full bladder increases the intra-abdominal pressure. So all these things, actually, the basic pathophysiology is a increase in the intra-abdominal pressure. So all those conditions which are precipitating the increase in the intra-abdominal pressure, like coughing, straining, obesity, prostatic symptoms, or any intra-abdominal tumor, all these things actually increases the intra-abdominal pressure, and because of that, there is the potential weakness develops the hernia. All these things lead to the abdominal hernia formation and collagen diseases as well, inherited imbalance in the collagen types. Already discussed about the collagen diseases. We know that the tensile strength of the wound or the tensile strength of the skin is given by the collagen. So whenever there's a deficiency of the collagen due to the inherited imbalance, maybe in the Ehlers-Danlos syndrome or maybe in the Marfan syndrome, all these things lead to decrease in the tensile strength, and there will be potential weakness. Why this is common in females? Because in pregnancy, we already discussed about that. In pregnancy, there's increase in the intra-abdominal pressure, and all these things are because of the increase in the intra-abdominal pressure. Common in old age. Already told you that in old age there is a loss of elasticity, there is a decrease in the collagen as well, and there's a less regeneration as well. So all these things basically precipitate to the formation of the hernias. Okay, composition. This is very important. Basically, because to understand, because whenever we are operating, whenever we are performing, we need to identify the sac. So we need to know what is the composition of the hernia. Hernia basically composed of the fundus of the sac. This is basically, you can see this is the sac, this is the neck. This is the skin, basically, which is overlying the sac. This is basically the wall, and this is the defect in the wall. So first of all, the fundus of this, you can see that this is the fundus of the sac. These are basically the hernial contents, which can be fat, which can be omentum, which can be bowel, maybe involving the small bowel or maybe involving the large bowel as well. So this is basically the body of the sac. Then you have the neck of the sac. Neck of the sac is the most important thing, because actually whenever the neck of the sac this is the narrowest part. You can also see here that the fundus and the body, they're broad, they're not narrow, but that goes down here, and the neck of the sac is the narrowest part. So neck of the sac is very important, because if the neck of the sac is very narrow, it can lead to the strangulation or obstruction of the hernia, and it can lead to further complications. We will discuss later in the lecture what kind of the complications can develop in the hernia. So this was about the neck of the sac. You can see this is the abdominal defect, and this is basically the peritoneum, right? If you can see, this is the abdominal wall, and this is the peritoneum. So let me tell you once again, this is the peritoneum, this is the abdominal wall, and here you can see the defect as well. So basically this is the defect. So what happens that whenever there's a defect in the abdominal wall, due to all those causes, I have already explained all the causes, there is a defect in the abdominal wall. So what happens that deep down we have the peritoneum. There can be the fat, there can be omentum, there can be peritoneum, and below, obviously we know that the bowel is inside the peritoneum with, so intra-abdominal or intraperitoneal contents, they can be herniated, right? So this is the fundus of the sac. These are the hernial contents. This is the body of the sac, basically neck of the sac. Neck of the sac is the most narrowest part. This is very, very important because when some of the hernias, they have a wide sac neck, but some of the hernias, they have very narrow sac, neck sac basically. So that actually leads to the strangulation, obstruction, and other complications as well. So let's have a look upon the types of the complex hernias. Basically, one is the occult hernia. So what do you how do you define occult hernia? By occult means something we cannot see by the naked eyes, right? So that means the hernia which is not visible. There's no swelling, but the patient is extremely painful. He complains you about the pain, but you don't see any swelling or apparent hernia visible on the abdominal wall. So these are called as occult hernias. They're very much complex because there's more chance, because they're very small. You cannot see them because they're very small, and the small hernias, there's more chance of strangulation, there's more chance of obstruction. So these hernias are very much complex. The other entity are the reducible hernias, and there can be irreducible hernias. So what are the reducible hernias? Reducible hernias are the hernias which goes back spontaneously on their own. The contents goes back into the peritoneal cavity. They're the reducible hernias. Or sometimes the patient tells you that whenever he is in the standing position or whenever he is coughing, the swelling is more visible. But whenever he lies down in a supine position, the swelling goes away. So these are the reducible hernias. But sometimes they don't go or they don't reduce by their own. You have to push them manually. But manually, when you push them, when you try to reduce them, they are reduced, they don't come back, they're the reducible hernias. So reducible hernias, they're not so complex, but irreducible hernias, they're very complex. There's a more chance of strangulation, there's more chance of obstruction. So these irreducible hernias are very complex as well, because whenever you try to push them back, they are firm, they're very firm, and if you try to push them back manually, they do not. So they are basically the complex hernias. The other complex entity is the strangulated hernia. How do you define a strangulated hernia? The strangulated hernia is the one basically whose vascular compromise has been established. What happens that those hernias which have a very narrow neck, actually there's impinging of the venous return, and obviously what happens that there's edema, and obviously because of that edema the vascular compromise develop. In such hernias they're called a strangulated hernia, and the patient present to you with excruciating pain. So these are also the complex hernias. Another entity is infarcted hernia. Infarcted hernia is the hernia in which a complete gangrene is developed. That means whatever the content, maybe the fat, maybe the omentum, maybe the bowel, but most commonly the bowel. Whenever there's a vascular compromise, that will lead to particularly and subsequently into the infarction or gangrene. So these are the infarcted hernias or incarcerated hernias. So they're also of the complex nature. So occult hernia, irreducible hernia, strangulated hernia, obstructed hernia, or incarcerated infarcted hernias. These are basically the complex hernias, and they can lead to, the patient can present to you with the symptoms of partial obstruction or total obstruction, constipation, vomiting, abdominal distension, and this is a surgical emergency. You have to shift the patient immediately to the operation theater, and you have to open the patient, and you need to release the obstruction, and you need to release the hernia. If not, there will be perforation, and there will be obviously there will be obstruction. So in that case, that's a surgical emergency. So what specifically you're going to ask the patient in the history? You will ask the patient about the age. Why the age is important? Because in the because the umbilical hernias, already told you, they're very much common before the age of 3 years, right? So sometimes by the age of 2 years, these umbilical hernias, they return back, they spontaneously regress. But sometimes after the age of 3 years, if they do not regress back, you need to operate the child. So age is important because in children, the most common hernias are the umbilical hernias. In adults, the most common hernias are the paraumbilical hernias. Or in case of aged, elderly people, most commonly, if we talk about the males, they're more of the inguinal hernias. They're very much common. In female, paraumbilical hernias are common. The patient will tell you about the swelling, about the particular swelling, that whenever I lie down, the swelling goes off. Whenever I'm in a standing position, whenever I cough, the swelling is more visible. So he will tell you about the swelling. If the hernia is strangulated or if the hernia is obstructed, the patient will, usually the hernias are painless. They don't cause any pain. But whenever they're obstructed, they're incarcerated, or they are strangulated, the patient can present to you with the pain. The patient, you'll ask the patient if she's pregnant, because I already told you the pregnancy is a leading factor. It increases the intra-abdominal pressure, so you need to rule out the pregnancy as well. Any history of intra-abdominal tumor, again, it increases the intra-abdominal pressure. Already told you all those conditions increasing the intra-abdominal pressure. Smoking, because actually what happens is smoking is, new research indicates that smoking is a very important constituent for the development of the abdominal hernia, because what happens, actually smoking it develops, it decreases the tensile strength. It decreases the tensile strength, and because of that, there is a potential weakness, and there's a more chance of the formation of the hernia. Previous scar means the previous surgery, because the wound strength is already gone, reduced by 30%. So more of the chances of the incisional hernia, there can be incisional hernia as well. In history, you'll also ask about the collagen vascular diseases. Already told you, because some kind of the inherited hernias, the genetic hernias, they're basically because of these collagen deficiencies, right? What particularly you're going to look in the examination? First of all, you need to examine the patient in a standing position, and you need to examine the patient in a supine position, because sometimes in a supine position, the swelling is not visible because it reduces back in case of the reducible hernia. And whenever you ask the patient to stand, and whenever he's in a standing position, what happens is like increase in the intra-abdominal pressure, and obviously that increase in the intra-abdominal pressure pushes the contents, and you can see the hernia becomes visible, right? So you will examine the patient in a laying position, or you will examine the patient in a standing position, right? And you'll ask the patient to cough. If there is a swelling more visible on the cuff, this is called as a positive cuff impulse. Usually the reducible hernias, they have the positive cuff impulse, but strangulated hernia, obstructed hernia, or irreducible hernias, they do not have a cuff impulse. Or you can say that the cuff impulse is negative. Whenever they cough, they are not more visible, or the swelling is not more visible, so they call as the cuff impulse is negative. And in case of the hernias like the strangulated, obstructed, incarcerated hernias, basically the cuff impulse is negative. But in case of reducible hernias, the cuff impulse is positive. So you will examine the patient in a supine position and in the laying position. These are basically the positions. And whenever you're examining the patient in a supine position, you will ask the patient to flex his legs, and you will ask the patient to elevate the head by 30 degrees. Here you can see that, because it tenses the abdominal muscles, and whenever if there's a swelling in the anterior abdominal wall, that is more, you can see it was deep inside, but whenever he flexes the leg and he also elevate the head, there is the tension in the abdominal muscles, and obviously the content is pushed outside and the hernia becomes visible. So that's how you can examine the patient. Now the thing, how you are going to make the diagnosis. First of all, the self-diagnosis. The patient will tell you that I have a swelling, and it's particularly, I think so, that it's a hernia, because most of the educated people, or most of the educated patients, they know that this is basically the hernia. There's something coming out from inside and it's forming a swelling. So one thing is a self-diagnosis. The other is you'll ask the patient about the symptoms. He'll tell you that whenever I'm in a supine position, the swelling goes up. Whenever I'm standing and coughing, or I'm doing some physical activity, the hernia protrudes. So he'll also tell you about the symptoms. You will ask the patient about the primary or recurrent hernia. You will ask the patient if there was the hernia and it was operated, and then he will tell you that there was a hernia, it was being operated, and now it's again there. So this is basically the recurrency. So you'll ask about the primary or the recurrent hernias. And the patient will also, I already told you, the hernias are mostly painless. They do not cause any pain until and unless they're obstructed, they're incarcerated, or they're strangulated, right? So in case of strangulated, obstructed, incarcerated hernias, usually the patient complains of pain, and the pain is like aching or heavy feeling. So these are the things you'll make the diagnosis on history, examination, and then obviously the investigations as well. Usually the hernia is a clinical diagnosis. It's apparently swelling, and you examine the patient and the cough impulse is positive. You touch and you can also feel the contents of the hernia by the pulp of your fingers. Maybe the hernia has a fat or a mentum or the intestine. You can feel it by the pulp of your fingers. So this is basically more over a clinical diagnosis. But still, if you are you're so absurd, you're not sure about the diagnosis, or there's occult hernia, and you need to go for further investigation. So what kind of the investigations, I'll tell you what kind of the examination, what kind of investigation particularly will order in a patient who is coming to you with a swelling. On examination, already told you, you'll see about the cough impulse, whether the cough impulse is positive or negative. If the cough impulse is negative, that's basically, there's no hernia mostly. But if the cough impulse is positive, it can be a hernia. Swelling with no cough impulse, it's abdominal hernia. But this is not hard and fast rule, because some of the hernias, like if the hernia is strangulated, if the hernia is obstructed, obviously the cough impulse would be negative, right? So you cannot say that it's a hard and fast rule. If the cough impulse is positive, it's a hernia. If cough impulse is negative, it's not a hernia. But obviously, if the cough impulse is positive and there's a swelling and you try to reduce the swelling, it's definitely the hernia. So, but if you are feeling a swelling, the patient is complaining, an examination, there's a swelling, it is irreducible, but the cough impulse is negative, that means that the hernia is obstructed, obviously, right? So in case of obstructed hernia, the cough impulse can be negative. But if the cough impulse is positive, that means a hernia. But if cough impulse is negative, that doesn't mean that there's no hernia, right? I hope so you get this point. Coming to the investigations now, a plain radiograph. This is not much of the importance, because in case if the hernia is causing obstruction, you can see the dilated gut loops on the plain radiograph, but mostly a plain radiograph, this is not of so much importance. It has a very little value, right? Ultrasound, this is very important, because you can see the contents. You can see this is the hernial sac, right? And this is the defect. So ultrasound will tell you the wall defect as well, right? So basically, this is the whole of the sac or whole of the hernia, and these are the contents, probably the intestines. So probably this is the bowel which is coming in the ultrasound. So the ultrasound will show you the defect as well and the contents of the hernia as well. So that's why ultrasound is very important. CT scan is basically the invasive modality, but here, see, you can see it's giving you more of the information about the hernia. a very precise information. This is the wall defect, and here is the herniation. In probably the intestinal contents, they're herniated and they're forming a swelling or the hernia. So CT gives you more of the better information as compared to ultrasonography, and plain radiograph it is of the low or very little importance as far as the hernia is not strangulated or obstructed. In case of strangulated or obstructed hernia, the patient can come to you with the signs of the intestinal obstruction, and there can be air fluid levels, or there can be the dilated gut lobes in case of the obstruction, right? So the other investigations include the magnetic resonance imaging, which is also a non-invasive, invasive investigation. It's not a non-invasive investigation, but in case of occult hernias, when we're not sure about the hernias and we need to actually find out or make the diagnosis, we go for the MRI in case of occult hernias. The other investigation, it can be therapeutic, it can be diagnostic. We go for the laparoscopy. We can insert the laparoscope through the port, so we can perform the surgery if we find any particular hernia. Otherwise, if there's no hernia, we move on. So regarding the management of the hernia, first of all, the thing is this: the familial hernias are always repaired, because mostly they're in a very narrow space and there's more chance of strangulation. So the familial hernias are always repaired, right? This is the rule. But other hernias, which are basically reducible and they're not causing any pain, or they're not symptomatically, they're not causing any pain, or there's no disturbance or harm to the patient, you can leave the hernia as it is. But mostly the thing is this: that the small hernias, they're more dangerous, because their neck is very narrow, and already told you that those hernias which have basically very narrow neck, they have more chance of strangulation, and there's more chance of obstruction as well. So the small hernias are very dangerous and they're always repaired. Femoral hernias are always repaired. But the other hernias, which are irreducible, which are not irreducible, and the patient is asymptomatic and they're very less, like maybe we can leave those hernias as it is. But if there's pain, tenderness, and strangulation, obstruction, we repair all those hernias. So these are basically the management goals. Regarding the management strategies, there can be open hernia repair, there can be Mayo's hernia, and there can be mesh repair hernioplasty, right? So first of all, we talk about the open hernia repair. It was basically a classical old modality used for that. What happens that we give a transverse incision in the midline, and we open the layers. We cut the fascia, the subcutaneous tissue. We basically goes deep down into rectus sheath is split, the muscle is split. We goes to the posterior rectus sheath. The defect is basically in the linea alba. So we basically, what happens that the peritoneum is the defect is closed, and obviously you can see here the defect is basically sutured. So the defect is closed, and then all the abdomen is closed in layers. This is the open hernia repair. The Mayo's repairs, in the Mayo's repair, what you do is actually you form the two layers basically from the anterior rectus sheath. One is the upper layer and one is a lower layer, and then what you do is that you create a flap from that anterior rectus sheath, right? Upper flap and the lower flap, and then the lower flap is actually that lower flap is traced back, is incorporated, and then obviously you can see here this flap is incorporated with that, and the whole of the layers closed. This is called the Mayo's repair. The other is a mesh repair hernioplasty, right? And most commonly today we are going for the mesh hernioplasties, because actually the mesh gives a tensile strength. We need to give the wall tensile strength so that there is no recurrence. In open hernia repair and Mayo's repair, there is more chance of recurrence, but in case of mesh repair, if you place a mesh over the defect, so there is basically recurrence rate is very much reduced. So nowadays mesh repair hernioplasty is the preferred strategy. Now, what are the surgical approaches like maybe you go for the hernia reduction. In case of the small hernias, like maybe if the hernia is 1 centimeter or maybe less than 1 centimeter, what you do is you just suture the defect in a figure of 8, right? Or the Dawn technique is applied. So in a figure of 8, you suture it, you close it because the defect is very small, you reduce the contents back into the peritoneal cavity, you close the defect, and obviously the abdomen is closed in layers in case of the small defect. But if the defect is greater than 2 centimeter, what you do is you go for the open drape here, right? What you do is like you incise, you go down, you excise, and the sac is identified, the neck of the sac is identified, the contents are reduced back into the peritoneal cavity, the peritoneum is closed, right? The extra part is excised, extra tissue is removed, the peritoneum is closed, and the defect is basically closed, and then the abdomen is closed in layers, posterior rectus sheath, and then rectus muscle is sutured, and anterior rectus sheath, and that's how you do it, right? So the important thing is you need to close the peritoneum, you need to push back the contents back into the peritoneal cavity. Or you also do the reapproximation of the walls of the hernia in case of surgical approaches. Or you do the permanent reinforcement. Basically, the permanent reinforcement is by the use of the mesh, right? So these meshes are placed just above the defect so that another tensile strength is added, and that's how you prevent the recurrence rate. So let's talk a little bit about the mesh types. There can be net meshes, which are basically the knitted. You can see here, these are the mesh. There can be the other synthetic meshes. There can be biological meshes, right? Or there can be tissue separating meshes, there can be absorbable meshes, right? So most commonly, we are using these net meshes, which are basically the synthetic meshes, and there can be flat sheets or they can be the synthetic knitted net-like meshes. So what happens, you can see here that this is a knitted mesh, or you can see a net here. So what happens that the small spaces in the net, you place the mesh over the defect and the tissue grows from these spaces, and that mesh is actually incorporated in the tissue, and it gives a tensile strength to the defect, and there is a lesser recurrence rate. So that's how these net meshes are helpful. But the flat sheets, they do not have these you can see these nets, so these are not incorporated and the tissue is not grown into that, right? Sometimes we also use the biological meshes, which are basically they have the antiseptic or antimicrobicidal effect as well, right? They have the antimicrobial or microbicidal effect as well. So these are the biological meshes. But most commonly we use these net meshes. They are not they don't have antibacterial or microbicidal activity, but actually they are you place the mesh in a space of 2 to 5 centimeter, right? And you have to secure the mesh from all the sides, like at least from the 5 sides you have to secure the mesh. Mesh can be placed over the defect, mesh can be placed under the defect, or mesh can be placed above the defect, right? So that depends. They can be inlay, onlay, or sublay. I'll tell you in the next slide, right? Mesh positioning. This is a subcutaneous space, right? Sometimes you place, and this is the anterior rectus sheath, this is the linea alba, this is the onlay space, right? You can say that the defect is in the linea alba, right? This is the point of the defect. And you have the subcutaneous space, and you place this mesh in this subcutaneous space. This strategy or this approach is called as onlay space, because you are placing the mesh over the defect, right? So the defect is, if the defect is in the linea alba and you are placing the mesh, or you're positioning the mesh into the subcutaneous space, this is called as onlay space. And if you are placing this mesh in the linea alba, this is called as inlay approach, or this is called as inlay mesh or inlay space, right? And this is the retromuscular space, right? Retromuscular is the space which is behind the rectus muscle, right? So you can also place the mesh in the retromuscular space, or you can place the mesh in the posterior rectus sheath, right? This was the linea alba, here was the defect, and now you are actually placing if you're placing the mesh in just the muscle is above and the posterior sheath is below, right? So if you are placing mesh here, which is the retromuscular space, this is maybe the sublay, this called as a sublay approach, right? This is the rectus abdominis muscle, and this is the last sublay space. Already told you, this retromuscular space is called as a sublay space. So you can place the mesh inlay, onlay, or sublay. Inlay is like you're placing the mesh on the defect. If the defect is in the linea alba and you're placing the mesh here, this is called as inlay approach. And if you're placing the mesh in the subcutaneous space, this is called as onlay approach. And if you're placing the mesh in this retromuscular space just behind the rectus muscle and was in front of the posterior rectus sheath, this is called as a sublay space. And you can also place, this is the peritoneum here, right? So you can also place the mesh in the preperitoneal space, in front of peritoneum, behind the posterior rectus sheath. This is the posterior rectus sheath. This is the basically the peritoneum. So you can place the mesh here. This is the preperitoneal mesh repair, right? So these are the places where you can place the onlay, inlay, sublay, or just preperitoneal space, right? So this is the extraperitoneal space. You can also, this extraperitoneal or the preperitoneal, this is the same thing. You can place the mesh in all these. It depends upon how much of the tensile strength is available to you. Now, what are basically can be the surgical complications? There can be a prolonged ileus, there can be a seroma, because if you're performing a surgery and you're not putting the drain into that wound or that space, there can be seroma formation, and the patient can again report to you with the seroma. There can be a suture side pain, there can be intestinal or the bladder injury, because obviously you're dealing with, if you're pushing the contents back into the peritoneal cavity, you can injure the intestinal contents as well. So there can be intestinal or bladder injury. There can be the cellulitis of the trocar side, because if you're doing a laparoscopic hernia repair and you're putting the trocar into the abdomen, so what happens that there can be a cellulitis because of the trocar side. There can be a mesh infection, because obviously mesh is a foreign body, right? So there can be a mesh infection as well. There can be hematoma or post-operational bleeding. The patient can have a respiratory distress. There can be trocar site herniation. And obviously, if the patient is very old age, there can be anesthesia risk, or there can be no bowel movement, right? Obviously, whenever you're performing a surgery, you may rupture the intestine. You can cause the intestinal injury. And in case of the intestinal injury, there will be no bowel movements. So all these complications, they are related to the surgery. If either you're doing open repair, or there can be a recurrence. If you're doing open repair, there's more chance of recurrence, and if you're doing mesh repair, there's less chances of there's less chance of the recurrence, because actually the mesh is giving a tensile strength. So basically this was all about the complications, and in this lecture I tried to be more general, but in the next lecture we would be more specific. We will talk about the detail paramylical hernias, umbilical, ventral, Spigelian, Spotsman's. So we will talk about that. So this was all about today's lecture, and thank you for watching sqadia.com. Thank you. Keep watching.